Originally, my mama daughter, na sasra. શું ચાલે? नहीं ध्यान नर्सिंग साहब ने क्यों पड़ेगा ना पाऊंगे देवी यहाँ गया क्या नहीं? नहीं किसी को फोन चाहिए हम चाह Hello, can you hear me? पता नहीं चलेगा. Hello. ये બીજી રૂમમાં લઈ જતો તો નહીં પણ મારો અવાજ આવે છે કે નહીં એ કઈ રીતે ખબર છે?
Sir, अभी बीपी हमारे पास NAM 7
હેલો. Can you hear me? Yes. You good to go? Oh yes, we can on time. हाँ पर आप कुछ हाँ चालू कर दो.
Yes. Hello, good evening, doctors. I just again welcome to all of you in the second session of the Indian Knee Arthroplasty Conclave. And it's our privilege that Dr. Manish Shah has joined us again. So I request sir to take the second session. So the session is on the TK exactly, which is the alignment coronal, sagittal, and axial. Sir, hand over to you. Kindly please give your valuable guidance to all the orthopedic fraternity, sir.
Thank you for the opportunity and the kind words. Can I share my screen now?
Yeah. Yes, sir. Yes, sir. Please. Yes, slides are visible.
Good afternoon, everyone. And as the summer heats up, we have a very hot topic today, and that is alignment. We all know that alignment is functional. If we were to look up at the dictionary meaning of the word functional, it means of or having a special activity, purpose, or task designed to be practical and useful rather than attractive. Something which works. But then in medical, as we all know, there are a lot many other words which have where functional is used. Functional pain is a term given to any pain that does not have a known organic cause. So that brings us to the fact that is alignment functional or is it a functional pain? Without much ado, let's get into it. Alignments we'll discuss along all three planes: coronal, sagittal, and axial. It all started with mechanical alignment, as we had seen earlier in the first session. Then came the anatomic alignment, constitutional alignment. In the 2010s came the kinematic alignment, and now the functional alignment. Let's go through all of them and see how they have evolved and where do we stand today. The clinical relevance of alignment comes in with survivorship and function. It's a battle between survivorship and function. Mechanical alignment with the older designs was meant to improve survivorship. The later personalized alignments, kinematic alignments, have been designed to improve function. And effectively, it's a battle between survivorship and function. Before we discuss various alignments, let's look at what are the reference axes that we are talking about. What are the various alignments, their strengths, weaknesses, and what are the 3D effects which come in from varus and valgus. The reference axis we're talking about is the hip knee ankle axis, the line joining hip center to knee center of the femur and knee center of tibia to the ankle center. And all are in one line. These form the mechanical axis of both femur and tibia. The femur mechanical axis is the line joining the center of the femoral head to the center of the knee. The femur anatomic axis is the mid-diaphyseal line through the femur. Femur knee joint line is the line joining the distal-most points of the medial and the lateral condyle. It represents the distal femur knee joint line. The lateral distal femoral angle. The mechanical lateral distal femoral angle is 88 on an average, varies between 85 to 90. And as we can see, the femur knee joint line is 2 to 3 degrees of valgus to the perpendicular and the mechanical axis. The angle between the anatomic and the mechanical axis, also known as the divergence angle, for knee replacements, we commonly refer that as a varus correction angle, 7 plus minus 2 degrees. So whenever we're using a conventional intramedullary rod, if we want to get the distal femur perpendicular to the mechanical axis, we normally aim for 7. If we want the femur joint line parallel to the mechanical axis, it's 5 plus minus 2. If we want it in varus, it has to be less than 5. Of course, in technology-assisted TKR, we refer to all angles from the mechanical axis. And that is why we aim for either 0 or 2 to 3 degrees of valgus. Tibia mechanical axis. It's the line joining the center of the knee to the center of the ankle. Anatomic axis is the mid-diaphyseal line. Both are parallel to each other. The knee joint line is the line joining the proximal most points of medial and lateral condyle of tibia. The medial proximal tibial angle on an average is 87, the range being 85 to 90. Thus, the tibial knee joint line is in 3-degree varus to the perpendicular and to the tibia mechanical axis. The joint congruence angle, the opening up of the joint in a normal relationship, varies from 0 to 2 degrees. So the key takeaways from what we've just seen is that mechanical axis of the femur and the tibia are parts of the same line. Femur joint line is in 3-degree valgus. Tibia joint line is in 3-degree varus. For intramedullary instrumentation, if we are aiming for a perpendicular or mechanical axis, we aim for 5 degrees correction. And if we are aiming to put the joint line in 3-degree valgus, the femur joint line in 3-degree valgus, we aim for 7. Naturally, TKR has different biomechanics, but these are the basics of alignment. Based on this, various different alignments have been described. There is mechanical, anatomic, adjusted mechanical, kinematic, inverse kinematic, restricted kinematic, and finally personalized or functional alignment. The mechanical alignment, the aim is to achieve perpendicular position to the mechanical axis. As the first modern TKRs developed, the designs and the stability, as well as the fixation methods, dictated that keeping it bang mechanical, perpendicular, ensured a good survivorship of the joint. And that is why mechanical alignment has withstood such a long history. And the main purpose of that alignment was to ensure that a modern TKR lasts longer. Cut the femur and tibia exactly 0 to the perpendicular to the mechanical axis. Thus, we convert the lateral distal femoral angle to 90 instead of 88. and we convert the medial proximal tibial angle to 90 instead of 87. It made up for the ease of instrumentation and ensured longevity of the joint. But then we know that in life, the joint line is at an incline, so that when we walk in the gait phase, the joint line becomes perpendicular or horizontal to the ground. Thus, anatomic alignment was propagated by Hungerford and Cracker, saying that we need to make the joint parallel to the ground when walking and when the leg adducts in the gait phase. The aim was to cut the femur in 3-degree valgus to the perpendicular to mechanical axis and tibia in 3-degree varus to the perpendicular to mechanical axis, thus kind of recreating what was there naturally. Given the fact that in that era, we had the same instrumentation, this was a little technically demanding. Then came Bellemans and Victor, who came up with the adjusted mechanical alignment. It's an adaptation of the conventional mechanical alignment with the goal to undercorrect the constitutional varus or valgus deformity to a maximum of 3 degrees. This was shown to lead to better functional results when the end varus was between 3 to 6 degrees. Recently, we have seen an upsurge for kinematic alignment, and the newer designs of the implants have been based on the fact that we will aim for a kinematic alignment. A medial pivot knee has been designed for kinematic alignment. The aim is to have a well-balanced knee throughout the arc of motion. To restore the normal knee function by aligning the distal and posterior femoral joint lines of the femoral component according to the functional axis of femur and tibia, effectively restoring the person to his normal or pre-arthritic status. How is this done? For the first time, instead of talking in degrees to the mechanical axis, Stephen Howell came up with the concept that if we were to measure the cut thickness and make up for the loss of articular cartilage, which has happened because of wear and tear, we would effectively restore the person to what he had naturally. Thus, correcting for cartilage and bone wear, and then cutting equal to the thickness of the distal and posterior femoral component, one could get back to the pre-arthritic alignment of that individual person. Thus, we had, for the first time, a calipered resection of the condyles. But then we know that what we are replacing has a different geometry. It does not follow the natural geometry. Each knee design is different. A single radius design does not behave the same as a multi-radius design. Some have a single mediolateral radius as well. Thus, putting them all into a natural pre-arthritic alignment might not be the ideal solution for everyone. But kinematic alignment have shown good results in terms of function, in terms of pain. And these results have been non-inferior to the standard mechanical alignment. And as we know that there will always be literature to the contrary. Thus, there are papers which say that kinematic alignment is a higher rate of revision compared to mechanical alignment. Mechanical and anatomic alignments use angles with conventional instruments to reach there. Kinematic alignment uses measured cuts to lead one to the same anatomic alignment. And papers on kinematic alignment show that good results are the ones where the final HKA was within 3 degrees. Inverse kinematic alignment, wherein the tibial cut is taken first. It is measured at 4 different points: anterior medial, posterior medial, anterior lateral, posterior lateral. And they have to be equal, compensating for the wear of cartilage and bone. If they are equal, we are restoring the native tibial alignment. Based on that, femur is gap balanced. Thus, we are able to achieve both a good balance and restore the natural tibial alignment for that individual. Restricted kinematic. In patients with greater deformities, they recommended that independent tibial and femoral cuts after compensating for cartilage and bone loss should be within 5 degrees of the bone neutral mechanical axis, with the resulting HKA within 3 degrees of it. This normally needs navigation or some other technological aid. The algorithm for a restricted kinematic alignment for varus as well as valgus. True kinematic alignment is possible only in 50% of cases. In the others, we would need a restricted kinematic alignment. Non-inferior or even better results with restricted kinematic alignment compared to mechanical alignment in short midterm. That's a systematic review in knee, November 23. It's also important to remember that besides these angles, we quite often lateralize the femoral component. Shifting the femoral component laterally shifts the axis into valgus, and the component is relatively in varus. It improves patellar kinematics. Shifting the tibia laterally also shifts the axis into valgus. And once again, that also improves the patellar kinematics. So quite often, when we just look at alignment, we do need to factor in the lateralization which comes in. And hence, for a pure kinematic alignment, they aim to keep the femoral component bang in center. If I were to look at the various alignments, the mechanical from the HKA is at 0, 0. With standard instruments, it's fairly easy to follow, but it does need some soft tissue releases, and the end function is good. The anatomic, we aim for femur in 2 to 3 degrees valgus, tibia in 3 degrees varus. It is slightly difficult, more difficult with conventional instruments. The joint line comes parallel to the ground in the gait phase. The amount of releases required are less, and the function is better. It's just a mechanical, wherein we undercorrect or restore the anatomy to within 3 degrees. It's fairly easy with conventional instruments. The amount of releases required are the least, and hence probably it has good results functionally. Kinematic, with calipered resection, femur and valgus, tibia and varus. Slightly difficult with conventional instruments. The joint line comes parallel to the ground. With a pure kinematic alignment, no releases are required, and thus gives probably the best function. Restricted kinematic alignment to within plus minus 5 degrees. So as we can look at this, amongst all mechanical, anatomic, adjusted mechanical, kinematic, restricted kinematic, we are aiming for that small corridor between 0 to 5 on either sides. For a 5.5 feet individual, a 3 degree error margin would reflect to 2.5 centimeter zone of error and a 5 degree zone of 4 centimeters. A narrow landing strip. Mechanical, anatomic, kinematic, adjusted mechanical, restricted kinematic. So probably the best thing to do is aim for the bullseye. If you miss, name the alignment achieved as your aim. As long as you are within that 5 degree zone, you will hit that area. No problems. PKR is a soft tissue surgery. Why increase the level of complexity at the bone level? Aim for the straight and narrow, it's easier. Try and keep the releases to a minimum. Decreasing the amount of releases improves the function. This is one of the landmark papers by Parrott and others. 20-year follow-up. Close to 400 knees were studied. No difference. Postoperative alignment of 0 to plus minus 3 degrees relative to mechanical axis. did not improve implant survival, and was not associated with better function at any time during a 20-year follow. Another interesting statistic. These are the cumulative percentage probability of revisions. And over the years, from 2003 to 2014, the graphs have not changed much. So the alignments which have been described so far within that narrow zone of plus minus 5 degrees really haven't added or taken away anything in terms of survivorship. Newer planning methods, the CPAC classification. Earlier, we used to look only at the HKA. Now we look at the medial proximal tibial angle and the lateral distal femoral angle. Yet, all planning effectively is still two-dimensional. Kinematic tibial cut is probably the first three-dimensional cut. That's the CPAC classification. The trend is to decrease the releases required, the belief that it leads to early return of function. But inadequate release will also lead to instability and poor survivorship. Aim is that over-enthusiastic releases should be avoided. Optimize and individualize, or personalize the pre-op planning with 3D plan templating to achieve the maximum benefit with minimum insult. Thus was born the personalized or functional alignment. Implant alignment to the mechanical axis and to the joint line anatomy with a balanced total knee. Besides getting the mechanical axis within plus minus 5 degrees, ensuring that the joint line is perpendicular to, parallel to the ground during gait phase, and ensuring that the knee remains completely balanced. It's important to understand the nuances of each individual and plan accordingly. Plan for what is the native and then how much one intends to correct. What are the other parameters that we should be looking at? The sagittal plane. Clinical relevance is anterior notching and the patellofemoral overstuffing. Like in the coronal plane, let's look at what are the reference axes, what are the various described alignments, how we do it. The femur mechanical axis is once again the hip center to the knee center in the lateral. The distal anatomic axis is the knee center to the knee intramedullary center. And on an average, the distal femur flexion angle varies between 0 to 6 degrees. This represents the bow of the femur. Normally, in conventional TKR, the distal cut is perpendicular to the intramedullary rod. And the intramedullary rod is in 0 to 6 degrees of flexion to the mechanical axis. Thus, in most of our patients with conventional instruments, we put the knee in some degree of flexion compared to the mechanical axis in the lateral view. This needs to be remembered as we now start using technological aids. That is why with navigation or with robotics, one needs to factor in and place the knee in some degree of flexion rather than aiming for a 0 degree to the mechanical axis in the lateral view. The other important parameter to understand is the posterior condylar offset ratio. The anterior cortex of the shaft, the posterior cortex of the shaft, and the parallel through the posterior edge of the condyle. The normal values are 0.44. Tibia mechanical axis, once again, like the coronal plane, is the knee center, tibia knee center to the ankle center. Like in the coronal plane, the tibia anatomic axis is collinear to the mechanical axis in the lateral. The knee joint line for tibia is the anterior edge of medial plateau to the posterior edge of the medial plateau. The tibia slope averages around 9 degrees. Thus, the key takeaways for a normal anatomy are that the distal femur flexion is 0 to 6 degrees. The posterior condylar offset ratio is 0.44. And the tibial slope is close to 9 degrees. But for a femoral component flexion, how do we measure on a short film? It's the distal anterior cortical line or a perpendicular from the flat surface or distal surface of the component or a line through the pegs. This is the line through the pegs. This is the flat distal surface of the component, a perpendicular through it, and the distal anterior cortical line. Here it's important to remember because we are following the distal anterior cortical line. This is 0 to 6 degrees to the mechanical axis inflection. The femoral component posterior condylar offset ratio is different from the non-replaced component ratio. Why? Because when we look at the X-ray with the implant in, the implant already has that cartilage thickness. When we replace the amount of bone and cartilage removed. And that is why a pre-op ratio of 0.44 becomes a post-op ratio of 0.47. Anterior condylar offset ratio parallel through the anterior edge of the femoral component. As we flex, this anterior condylar offset decreases. The tibial component perpendicular to the tibial anatomic axis and parallel through the base plate of the implant. You measure the perpendicular to the tibia anatomic axis and the parallel through the base plate of the tibia. Thus, the sagittal alignment variables are femur component flexion, femur posterior condylar offsets, tibial slope, and depth of the proximal tibial cut. A very large series, more than 1,000 patients, and they found that the distal femoral flexion angle was 3 plus minus 1.5. And they said that in 11.4% Asians, this was more than 5 degrees. Thus, while using imageless navigation or imageless robotics, aim for at least 2 to 3 degrees of flexion. Femoral component flexion increases posterior tibiofemoral translation or the rollback. It reduces the quadriceps force and the patellofemoral contact stress, and there is less fear of notching. The posterior tibiofibular translation or the rollback increased by 2.8 mm as the component was flexed from 3 degrees of extension to 7 degrees of flexion. It increases the quadriceps momentum and decreases the quadriceps force. It also decreases the patellofemoral contact stress. And it's important to remember that with navigation or imageless robotics, when you're aiming for 3 degrees, effectively the flexion from the anterior cortical line would be 0. Because the distal femur is flexed compared to the mechanical axis, if we were to aim for almost a 0 to the anterior cortical line, we would be in the range of 3 degrees of flexion. Ten-year case control study, 297 patients. Extension of more than 5 degrees, 0.5 degrees to the reference anatomic axis, which is the distal anterior cortical line, predicted anterior knee pain in 87% patients. This was also accompanied whenever there was a valgus tibia. Moreover, as we flex the component by 3 degrees, the effective anteroposterior diameter decreases by approximately 2 mm, thus leading to a decrease in the size of the femoral component by 1, and hence the mediolateral overhang in zone 1 and 4 go down by approximately 3 mm. Every 2 degrees of flexion decreases AP distance by 1 mm. How much flexion is too much flexion? In a 1 year post-surgery, more than 5 degrees of FFT was predicted when the flexion was more than 3.5 degrees to the mechanical axis. The risk of a fixed flexion deformity increases 2.9 times. So as we can see from here, the range is very narrow. one needs to ensure that we are fairly flush with the anterior cortical line to prevent too much of flexion. Yet another long-term study with a good number, 3,000, more than 3,000 knees, flexion more than 3 degrees with reference to anatomic axis. So this is flexion which is more than 6 or 7 degrees to the mechanical axis, predicted lower survival. In our own study of the angle between the mechanical axis and the distal anatomic intermediary axis in 407 osteoarthritic knees, we came up with the same results. We should aim for 3 degrees of flexion to the mechanical axis, and we should aim to be parallel to the anterior cortical line distally. Posterior condylar offset is significantly greater in excessively flexed group, and hence they have a significantly lower range of motion. Thus, both anterior extension group as well as excessively flexed groups end up with lower range of motion. Extension is equally bad. In excessively flexed components, anterior end of the processes cuts into the patella, resulting in microfracture of the patella and anterior knee pain. Femoral processes extension was one of the independent predictors of anterior knee pain because it increases the anterior offset. Thus, the key takeaways are that mild flexion is good. It decreases the anterior condylar offset ratio. It decreases the medial lateral width by decreasing the size of the component, and it improves balance. But extension is bad. So, in a technologically aided TKR, aim for 3 to 5 degrees to the mechanical axis. After looking at the femoral bow and the anterior cortex plane, and for those using conventional instruments, aim for the least possible flexion to prevent a fixed flexion deformity. (150) consecutive CR knees, posterior offset correlated well with eventual range of motion. Decrease in that offset ratio leads to early impingement by the tibial tears striking the posterior cortex of the femur. So decrease by 3 mm led to decrease in flexion by 10 degrees. Important to note that there is no difference in offset with either anterior or posterior referencing systems. So whatever you are conversant with, anterior or posterior referencing systems, you can use them safely. Tibial slope on an average 0 to 7 degrees. Higher slopes have higher failures. And there is instability with reverse slopes. In our population, which has very high slopes, putting them completely in a natural position might jeopardize the mechanical stability of the implant. And that is why aim for a desired between 3 to 7 degrees. In our study of 300 patients undergoing TKR, 1 in 3, almost 1 in 3, had a difference of more than 5 degrees between medial and lateral slope. Posterior slopes of 10 or more degrees in more than 3/4 of the patient. And more importantly, many of our patients have a lateral slope which is more than the medial slope. As you can appreciate here, the lateral slope is more than the medial slope. Probably as a squatting population, we tend to exert more on the lateral posterior, increasing the slope and thereby making the rollback a lot easier on the lateral side. In summary of sagittal alignment, flexion according to the bow, get the offsets correct. If you're using an intramedullary rod, aim for 0 to 3 degrees. In a non-intramedullary rod setup with a technological aid, aim for 3 to 5 degrees. Tibial slope, aim for 0 to 7. And as we have seen with the coronal, effectively, what it tells us is that it is important to understand the native anatomy and remain within that 2 to 3 degree range, both in terms of millimeters and in terms of degrees, to get to the ideal solution. Coming to the axial plane, probably this has been the least described amongst alignments. How is it clinically relevant? A trapezoidal gap, mal-tracking patella, and the post striking the component. The post in the polyethylene striking the component. This is where the rotational alignment comes into play. Once again, we'll go through the normal rotations, the normal reference axis. How do we look at rotation in measured resection? How do we look at rotation in gap balancing? And what are the 3D effects? For rotation, we normally look at a good lateral coverage, posteromedial area a little uncovered, a good curve on curve of the natural condyle matching the curve of the tibial tray, and running the trial through the full arc of flexion to let the tibial base plate home in on the correct rotation. The midline of the base plate along the medial border or medial 1/3 of the tibial tuberosity. The posterior condylar axis is the line joining the posterior-most point of both condyles. It's the easiest to identify in surgery. The surgical transapicondylar axis, the line joining the surgical medial epicondyle to the lateral epicondyle. It represents the origin of the collateral ligaments. And aligning it in this position maintains the isometricity of ligaments for the flexion extension axis. The white side line is the line joining the deepest point of the patellar groove to the highest point of the intercondylar notch. It represents the anteroposterior axis and normally is perpendicular to the transepicondylar axis. And probably one of the most important parameters is the proximal tibial cut surface axis. The line representing the proximal tibial cut surface at 90 degrees of flexion, irrespective of the femoral anatomy. Aligning the femur component to this ensures balance throughout the arc of motion. Importance of these axes. Whenever we put in any sizer, all the instruments have legs which rest underneath the posterior condyle. And hence, any sizer aligns itself with the posterior condylar axis. And then we rotate that accordingly to match the desired position. Surgical transapical axis is normally used when anatomic landmarks are well defined. Femur AP axis is used when anatomic landmarks are difficult to find. But proximal tibial cut is the one which is used most commonly when balancing a trapezoidal flexion gap, ignoring the anatomic bony considerations of the femur. As we know, two operative techniques have evolved: measured resection and gap balance. Gap management basically is a continuous interplay between collateral ligament balance, symmetrical flexion and extension spaces, and the mechanical axis. When we achieve all three, we have a balanced TKA. In measured resection, we reference the bony landmarks. We aim to take out only what we aim to put in. Resect measured amount of bone. Remaining soft tissue releases are done, and probably is the most reproducible techniques with conventional instruments. In gap balancing, the tibia is cut first based on the tibial cut in the coronal and the sagittal plane. Flexion space is determined. Femoral rotations are based on this cut and the collateral ligament tension. Ideally suited for a single radius design. But as we all know, that in a measured resection, when we set it at just 3 degrees, only 1 in 3 of the Indian population had a 3-degree external rotation. This was a study by Dr. Gurva Reddy, published in 2016. Soft tissue release is difficult to fine-tune because they give unpredictable amount of opening up of the joint space. And that is why with gap balancing, what is most commonly done is that 90% of the releases are done earlier. Once you have the desired correction, the tibial cut is taken precisely, and then the femur is placed on depending on the balance achieved with tibia. But then what happens is that if the tibia cut is in varus, the femur will internally rotate. Whereas if the tibia cut is in valgus, the femur will externally rotate. If the tibia cut is inadequate, it will increase the cuts in the posterior as well as distal femur. Whereas a flexion deformity will cause marked raising of the joint line. So with gap balancing, getting the tibia depth and axis correct is very, very imperative. The middle path is measured resection with extension gap first, tweak the rotation according to the anatomy. and based on the proximal tibial cut. This is an interesting comparison. Where do we get the anatomical landmarks correct? Based on CT scan and either navigation or conventional instruments, getting the transapical axis correct with navigation was in less than 50%. Whereas with gap balancing, achieving a transapical axis was close to 80%. Once again, a navigation study compared with CT scans, surgeon identified location and its variation from the true location, medial epicondyle off by close to 2 centimeters, and lateral epicondyle close to 1.5 centimeters. The surgeon's ability to reproducibly identify the bone landmarks accurately used in measured dissection techniques is limited. Because the gap balancing technique is less dependent on bony anatomy, we feel it can be used to provide a more reproducible flexion gap stability. A head-to-head study, patient-related outcome measures, proms at 2 years follow-up, gap balancing was superior. Though it took a lot more time, close to an average of 16 minutes, more than compared to measured dissection. The key is getting the bridge or bridging the gap between measured dissection and gap balancing. Important to assess the patellar tilts. Effects of rotation. Externally rotating the femoral component increases the medial flexion space. It increases varus during flexion, improves congruity in cases of maltracking patella, but it increases component size. So there might be a mediolateral mismatch. And as we can see, different patients have different rotations. It's important to understand the individualized anatomy. A new kid on the block is the quadriceps vector. How do we measure the quadriceps vector? The center of the medial condyle of the femur distally and the center of the femoral head. That line, the line joining the center of the medial condyle to the center of the femoral head, that's the line representing quadriceps vector. Aligning the trochlear groove of the component to the quadriceps vector helps in achieving a good quadriceps function. This is something which we very commonly see with robotics. Gap matrix, or measurement of the gap in extension and flexion, both medially and laterally. How many possible combinations can be achieved? This is a paper worth reading, and I would strongly recommend that everyone goes through this. Published in Journal of Arthroplasty, 2023. Solutions with soft tissue releases. STR is soft tissue release. 8,027. More than 8,000 possible solutions are present. So even if someone says that I'm using robotics, he's using one of the possible 8,000 solutions. It does not mean that one robotic surgery is the same as the other robotic surgery, because both of them need not have used the same solution of the 8,000 possible combinations. The percentage of TKAs which achieved equal gaps with mechanical and kinematic alignment. And as you can see here, even with a plus minus 3, it is only close to 50% that equal gaps could be achieved. If we allowed for a lateral gap laxity, even then, 79% with mechanical and 88% with kinematic. %79% needed one recut with a robotic TKR. 19.3% needed two bone recuts. Equal gaps come with only 50% cases with either mechanical or kinematic. The aim has to be that we are remaining in the zone and we are getting adequate balance. It is not just a question of alignment. It is not just a question of balance. It is both alignment and balance. A lot of our patients have triangular gaps to begin with, and some compensatory bone cuts probably makes it easier to achieve a rectangular gap and good balance. Thus, in personalized alignment, what do we aim for? Lesser releases, slight undercorrection, restoration of the joint line and its orientation, achieve full extension on table, flexion a little looser than extension, lateral a little looser than medial. Question is, do we understand the personalized anatomy? And that makes a very strong case for surgeon-based 3D planning. Alignments can be debated endlessly. But the need of the hour is to assess the patient in all three alignments, coronal, sagittal, axial, understand the possible ramifications, aim for a slight undercorrection, and have a balanced day. Thank you.
Thank you, sir.
I guess I've slightly overshot my time.
Thank you, sir. Thank you for your guidance and your session on the alignment. This session is exactly very helpful to all the doctors. We are having the few questions right now with us, and consistently we are getting the questions. I'm just sharing the few questions with you, sir.
Yes, please. One of the first questions that I've received is, how accurately can we plan a case without relevant clinical information on the underlying fixed flexion deformity? See, conventionally, as we know that whenever we are dealing with a fixed flexion deformity, our extension gap is smaller than the flexion gap. And hence, we normally take a larger distal femoral cut. If we are aware of the native anatomy, then probably the depth of cut would need to be decreased. As they say with kinematic alignment, in fact, you distalize the joint line a little to achieve better balance. Thus, it's important to have good clinical information prior to walking in to surgery. Let's say that you do not have access to technology and you are planning a patient of a fixed flexion deformity. What would I be looking at? I'd be looking at what is correctable under anesthesia and what is not. One. Then achieving the standard releases pre-operative, before taking the bony cuts. I would aim to correct a fair amount of varus valgus, which is there. That will also help in correcting a fair bit of flexion deformity. I'll aim to use a slightly more constrained implant in terms of rather than going with a pure CR, might use a PS knee. And then, based on the amount of deformity that remains, I will always check my extension gap before proceeding to taking the APCC cuts in these cases. Occasionally, I might upsize the component a little if the medial lateral permits, thereby decreasing my flexion space. And then I can compensate that by a slightly larger tibial cut and ensure that I have not elevated the joint line too much. The next question is, how can we precise position on flat surfaces like this plastic trochlea in a valgus knee? The position of the trochlea is fairly dependent on the mediolateral sizing of the implant and the knee. The conventional teaching has been that you aim to lateralize the component so that it catches the patella easier. So in cases of dysplastic trochlea, I would normally aim to lateralize as much as possible within the constraints of the mediolateral. How to improve the pinning capacity? In osteoporotic bones, one needs to be extra cautious in pinning, and over enthusiastic pinning also can lead to loss of bone. Hence, in these cases, what is normally more important is that as you take the cut, you do not force yourself on the jig. If you are trying to force yourself into flexion while taking the interior cut, the pins will not hold in an osteoporotic bone and the APCC jig might tilt this way or that way. And that is why one needs to ensure that while using the saw, you're not forcing yourself on the jig. how to reduce cutting errors through alignment techniques in TKI. Just keep on shooting. There are lots of questions coming in, and I'm not sure if we have the luxury of time to address all of them.
Yes, sir, exactly. After this question, I think that we should close, and whatever the question becomes, we can directly connect with the doctors. Exactly.
Maybe we could do that.
Yes,
but
sir.
then I'll try and answer as much as I can. Do let me know the time which I have. One was, how do we reduce cutting errors through alignment techniques in TKI? One of the safer techniques to follow is that we normally take the anterior chamfer before taking the interior cut, so that if you happen to notch or you are about to notch, you will be able to pick it up much earlier. When you're going with the interior cut first, quite often you do not know where the blade will exit. So these are fairly independent of alignment techniques. Reducing the cutting error is being aware of what alignment that you are aiming for, and then ensuring that your jig doesn't wobble and the saw doesn't wobble. One of the other simple things is that get a good blade every time you go into a case. Probably that will give far more accuracy than any other technology that you might use. Going in with navigation and using a blade which is 10 surgeries old probably is never a good idea. I'd rather go conventionally with a fresh blade in every case. How should the femoral component be positioned in cases of patella baja and patella alta? Normally, what we aim for is to restore the joint line. Patella baja might lead to some restriction of range of motion, and distalizing the femur a little, taking a slightly deeper tibial cut might improve the patella baja to a certain extent. But then we know that there's a limit to which you can do. Here we are talking in terms of a couple of millimeters. We're not talking of 7 millimeters or 1 centimeter. No, we're talking of 1, 2, 3 millimeters at the max.
Thank you, sir. Thank you for giving your guidance on the alignment session.
Thank you.
So,
and we'll be happy to take the questions which remain in the next session.
yes, sir. Yes, sir. We will take all the questions in the next session because the time is not permitting to us. So we will take now the other questions in the session 3 itself, sir.
Thank you.
Yeah, thank you, sir. Thank you for your guidance.
Thank you.
Thank you. Thank you, sir.